So welcome, everyone. Thank you for coming. Thank you for joining us for the first lecture in 2026. Today's topic will be gynecological cancers, what every woman should know. We'll be learning from our amazing speakers, Dr. Thomas Morrissey, GYN oncologist, and Dr. Hina Saeed, radiation oncologist. Both of these physicians work with us at the Lynn Cancer Institute. We're very fortunate to have them, who both are deeply committed to improving the lives of the female patients in our community. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, and the expertise of our staff, as we're seeing today, and as well as the benefit of our multimodality method of treatment, all combined will truly save lives. In the interest of time, their bios were sent to you by email. And during the presentation, we invite you to please take notes. And if you have any questions, please put them in the chat box or in the Q&A. And the doctors will have time at the end of the presentation to address your questions. So thank you. And Dr. Saeed, thank you for being flexible. And we will start with Dr. Saeed, our radiation oncologist.
Hi, thank you so much. Good afternoon, everyone. Happy New Year, and welcome to our first session for this year. I am Dr. Hina Saeed. I'm the radiation oncologist, part of the Lynn Cancer Institute team, and really providing the GYN radiation oncology services for the entire Baptist network in the Northern Tier. So let me just start with sharing my presentation. As a radiation oncologist, this is what we're going to be talking about. So in general, when we have any cancer diagnosis, there are three people who are going to be primarily part of your team. One is going to be the GYN oncologist, such as Dr. Morrissey, who's a surgeon. The other one is going to be the medical oncologist, who provides cancer treatments through systemic options such as chemotherapy and immunotherapy. And then people like me who provide treatments for cancer using radiation treatments. So statistically speaking, there are approximately 2 million new cancer diagnoses every year in the US, with about 618,000 cancer-related deaths, and that's per ACS in 2025. Around 117K of these cases are gynecologic cases, with over 33,000 deaths resulting annually from these cases. So just to give you an idea, for every 100,000 women, 8 new cervical cancer cases were reported, and 2 women died of this cancer every year. Per 100,000. For every 100,000 women, 10 new ovarian cases were reported, and 6 women died of this cancer. For every 100,000 women, 28 new uterine cancer cases were reported, and 5 women died of this cancer. For every 100,000 women, 0.6 or 1368 women got diagnosed with new vaginal cancer, and then 0.2 or 431 women died from vaginal cancer. For every 100,000 women, 2.6 new vulvar cases were reported, and 0.6 cases or 1,347 women died from vulvar cancer. So to give you like a little bit of a recap to so that everyone understands, the most common GYN malignancy remains endometrial. The least common GYN malignancy remains as vaginal cancer. The most deadly GYN malignancy remains to be ovarian cancer. And typically the reason why is that it's found later in the course. It's not diagnosed early. Things can progress in the abdomen, pelvic area until a patient realizes that something is wrong. So let's talk about a few misconceptions commonly held by the public, and we are trying hard to make sure that those are addressed and people understand what the facts are behind them. So the myth number one, gynecologic cancer only affects older women. The fact is, While it predominantly affects women after menopause, gynecologic cancer can also develop in young women, and primarily that's very much true for cervical cancer, and especially in endometrial cancers that are associated with a certain genetic condition. We call it the Lynch syndrome. So another myth, the pap smear will pick up all types of gynecologic cancers. But the real fact is that this test actually just tells us what is the condition of the cells lining the cervix. It identifies the abnormalities that could develop into cancer only of the cervical region. It does not really test for other GYN malignancies. So another myth, there are really no symptoms. It's a silent killer. Well, that's actually not true too. So many women would experience some early symptoms, but these symptoms typically tend to be non-specific and therefore often ignored. Symptoms include abnormal vaginal bleeding or discharge. That is common for in all GYN malignancies except vulvar cancer. Feeling full too quickly or difficulty eating, bloating, abdominal or back pain are common for ovarian cancer. The problem is that many of these patients, especially in the premenopausal, menopausal states, would experience some kind of a bloating. As we get older, back pain can occur very commonly in women too. So those symptoms can be very non-specific, but it's a good idea to make sure that you always approach your medical provider to discuss these symptoms. Okay, so this is what we talked about before. Misconception, and I'll go through it very quickly now because you've already heard that. So this is not true. GYN cancers affect women of younger women as well, not just women after menopause. The pap smear picks up all types of GYN malignancies. That's not true either because it's really looking at the abnormal cells lining the cervix, but does not really test for other GYN malignancies. So there are no symptoms. It's a silent killer. The real fact is that abnormal vaginal bleeding or discharge is common in all GYN cancers except vulvar cancer. So sometimes those abnormal bleeding episodes that can be attributed to perimenopausal periods need to be attended to. Feeling full too quickly, difficulty eating, bloating, abdominal back pain should not be attributed to, again, perimenopausal symptoms or to older age, but they need to be taken care of by talking to a medical provider, especially if they're not being resolved, if they're consistent and there's no temporary fix. Pelvic pain or pressure, that is usually common for ovarian and uterine cancers. As things start growing in the pelvic area, some women can feel that. Another is more frequent or urgent need to urinate or constipation. And these are commonly found in ovarian and vaginal cancers too. As these cancers become bulky, they start impinging on the bladder, so that women would feel that there's an urgency to go and urinate. Sometimes it might start hitting the bowel area so that the women might experience constipation. Itching, burning pain, tenderness of the vulva, changes in the vulvar color or skin, such as a rash or sores or warts. These are typically found only in vulvar cancer too. So people with gynecological cancers typically have multiple partners. That's a myth. Actually, you can get any of these cancers even if you're a virgin. Another myth, you cannot get a GYN malignancy after hysterectomy. So this surgery does not prevent cancer developing in other parts of a woman's reproductive system, such as the vulva or the vagina or the ovaries. Today's survival rates for GYN malignancies are high, and as we talked about before, that's really not true. The detection and treatment of the gynecologic cancers have improved significantly, but the survival rates are still lower than that of breast cancer, especially as we talked about in terms of ovarian cancer. Another myth, if I lead a healthy lifestyle, I cannot get cancer. We do know that obesity and adverse lifestyle factors such as smoking are directly linked to GYN malignancies like endometrial cancer, but there's no proven diet that that prevents cancer. Many women come to me and they think that they are on a high antioxidant diet. Would that help in and how did they get the cancer? So somehow there's a kind of a misconception that's probably out there due to social media that having a good lifestyle might prevent that. Having a good lifestyle is great as far as treatment efficacy is concerned. It does lower your risk of being diagnosed, but we don't really exactly know which foods may fight or prevent cancer. It's always a great idea to have a diet rich in vegetables and fruits and nuts, and less of red meat. But it's a good idea to make sure that having this kind of a healthy lifestyle would not prevent you from being diagnosed. Our advice is to maintain, again, a balanced, healthy lifestyle and avoid risk factors like alcohol, obesity, smoking that are known to be linked with GYN malignancies. I have no family history of cancer, so I probably wouldn't get it. Again, the real fact is most women diagnosed with GYN malignancies have no family history. Again, an exception would be people with Lynch syndrome. They have cancer diagnosis, especially pertaining to endometrial ovarian in the family, but that's usually not the most common scenario. Our advice would be closely monitor your body for changes. Remember that ovarian cancer, there often aren't any early warning signs that are specific, but make sure you go and see your medical provider if you're seeing any of these non-specific signs consistently. Survival rates for GYN malignancies are much higher when women seek medical attention as early as possible, and I cannot emphasize that more. I have seen many patients lose their lives for cancers such as coming from the endometrium or cervix when those are actually very treatable malignancies if diagnosed early. So please remember that. Doesn't matter if you have a non-specific symptom, you go to your PCP or your OB/GYN, it's okay if they tell you that's fine, there's nothing to worry about, but at least get yourself checked out. I'm getting older, so my risk for GYN malignancies is getting lower. That's not true either. The risk of women being diagnosed increases beyond the age of 65. So in the world of GYN oncology, we often say that being 65 or older is a known risk factor. So risk factors for GYN cancers, HPV and cervical cancer. Persistent infection with a high-risk HPV strains, such as those that we commonly think about, HPV 16 and 18. It is a primary cause of cervical cancer, and it highlights the importance of vaccination as well as regular screenings. Obesity's role in uterine cancer. Excess body weight increases estrogen level, significantly raising the risk of endometrial cancer and necessitating weight management strategies for prevention. Genetic predispositions in ovarian cancer, inherited mutations such as BRCA genes, especially BRCA2, greatly elevate ovarian cancer risk, underscoring the need for genetic counseling and proactive health measures. So remember these three things: HPV with cervix, obesity with uterine, and genetic predispositions in ovarian cancer. So how are these cancers typically treated? If your doctor says that you have a GYN malignancy, then definitely ask to be referred to a GYN oncologist. Again, I cannot emphasize that further. Do not have a surgery with a regular OB/GYN or gynecologist. These people are not trained to handle a malignancy. And importantly, if your surgery is not as good as it would be, any other adjuvant treatment might not be efficacious as well. So it's super important to make sure that once a patient is diagnosed with gynecologic cancer, they immediately ask to be referred to a GYN oncologist such as Dr. Morrissey, who has a specialization to deal with these kind of treatments, with these kind of cancers. So different treatments may be provided by different doctors. on your specialized cancer team. I kind of like talked about this a little bit earlier. Medical oncologists, again, are doctors who would prescribe immunotherapy or chemotherapy to treat malignancies. Radiation oncologists, such as me, are people who would treat cancers with radiation. So gynecological cancers are treated in several different ways. It depends really on the kind of cancer that you have. The multiple cancers that we talked about, endometrial, uterine, cervix, vaginal, vulvar, and how far it has spread. That also necessitates what kind of treatment you would be getting. Women with GYN malignancies often get more than one kind of treatment. It's kind of like uncommon that they would need only one treatment. Um, Against surgery, doctors such as Dr. Morrissey would remove the cancer tissues in tissue in an operation. Chemotherapy, essentially those are medications that would shrink or kill the cancer. And radiation, I would use high energy rays, such as similar to X-rays, to kill the cancer in a non-invasive fashion. So what types of radiation are used for treatment? So really there are two main types of radiation therapy delivery that are used to treat GYN malignancies. We call them external beam radiation therapy and internal radiation therapy, such as brachytherapy. In external beam radiation therapy, I would have the patient lying on a treatment table, and there's a machine around the patient that would aim radiation at a specific part of the body. And that includes photons, protons, and electrons. In internal radiation therapy or brachytherapy, we would use a radioactive source that is placed inside your body, either in or near a tumor, to kill the cancer cells. So how can radiation therapy be used? It can be used in different ways to help treat gynecologic cancers, such as for after surgery, for a cervical, endometrial, and vulvar cancer diagnosis. Radiation therapy may be used for patients who have intermediate or high-risk features, such as positive lymph node or positive margins or closed margins detected after surgery. So remember this. For these three kinds of malignancies, cervical, endometrial, vulvar, radiation therapy, even after surgery, can be used in case there are certain high-risk features that might need radiation for optimal local control, even if your surgeon says, we got it all out. So radiation can also be used for endometrial cancer patients who are not surgical candidates. So many a times we might have patients who are far too old or elderly, or might have many medical comorbidities so that they're not optimal surgical candidates. In those patients, radiation can be used as well. Definitive radiation therapy can be used for certain malignancies, such as locally advanced cervical cancer and vulvar cancer, which can be very, very morbid and will not provide effective local control, only with surgery. So at that point, radiation is used sometimes with chemotherapy, but it can be used alone as well to make sure that without the use of surgery, patients are treated with curative intent. Since vaginal cancers are usually not caught early, they're also treated at times with radiation or chemoradiation. In case where vaginal cancer is caught very, very early, surgery can provide effective treatment. So what should I expect before treatment? This is a good question that patients normally ask me. So before starting radiation therapy, you will have an initial consultation with me to decide if radiation is right for you based on the risk factors that you have, and to review the treatment consent. After that point, you would have CT simulation. You'll be placed in the position you will be in for your treatments, and pictures will be taken of the inside of your body. Immobilization devices you'll be placed within an immobilization device, so that you're lying still during the treatment and you're not really moving that much. You might be given a tattoo or so that you're lying in the same position for every treatment. We will obtain, together with CT simulation, and MRI or a PET-CT that will be fused with the CT. Internal organ motion with respect to your bowel and bladder is also noted and will play a key role in your radiation treatment plan. So as your radiation oncologist, I will decide how many treatments you'll receive and how often. And usually it's a team-based approach. There are many, many people that are working in your radiation care team. Some you will meet, and others others will stay behind the scenes, but a lot of them actually will be behind the scenes for you. So what to expect during a procedure? Anesthesia is typically not required as it is non-invasive way of delivering treatment. The patient will be lying on the table with the required immobilization devices, holding the body in the given position. And the radiation device really moves around in different directions around the affected area to deliver the high energy X-rays. Radiation enters your body, exits your body, will not make you radioactive either, and is painless. What to expect after a procedure? Hospital stay is typically not required. The affected area, especially when I'm treating a vulvar lesion, can become sore, and recommended prescribed lotions or creams can be applied for relief. Other side effects may not be immediate, but occur slowly after the procedure. So it's a good idea to make sure that we are looking for symptoms and take care as recommended by the physician and the nursing team. Adequate rest is usually required after the procedure. No need to have more on your schedule than needed at that time. And avoid direct sunlight. So what is LCI's approach? And this is where we kind of take a lot of pride in ourselves and how we deliver these treatments. Detect cancer early, tailor the treatment to your circumstances and needs, and maximize chances for a positive long-term outcome. There's an entire multidisciplinary team that's working on the sidelines to make sure that your care is delivered in a very optimized manner. Our oncology team draws on the latest research findings to diagnose your cancer as early as possible, and then we offer the most effective treatment plan for the type and stage of your cancer. So if an endometrial cancer comes to me, that person will not be getting the same endometrial cancer treatment that I would have offered to the patient before that one. We understand the impact the gynecologic cancers can have on your fertility, sexual functioning, and psychological health, as well as on your family. And adequate referrals will be made to make sure all of these needs are taken care of. We also take your age, health, and plans for having or growing a family into consideration when recommending a treatment option. And then we use our training and experiences to tailor treatment options to maximize the impact on your fertility and sexuality. So at LCI, we are very, very lucky to really have a plethora of technology and many personnel available to deliver your treatment very precisely. At Lynn, our problem is not, can I take care of you? Our problem is, what tool do I use to take care of you? We have dedicated radiation oncology staff and clinical nursing and with clinical nursing and technical expertise for treating GYN malignancies. We have state-of-the-art variant true beams that can offer volumetric modulated arc therapy, intensity modulated radiation therapy, and image-guided radiation therapy. We have Radixact with tomotherapy technology that is very effective when treating long GYN fields, such as those found commonly in endometrial or cervical cancers. We have CyberKnife that can deliver stereotactic radiosurgery or stereotactic body radiation therapy for any ablative localized disease, especially in the recurrent setting. We have an elective flexitron afterloader, which is what we use for delivering brachytherapy. We offer world-class MRI-guided real-time adaptive brachytherapy for each of our brachytherapy fractions on a daily basis. We also have MR-Linac capability for adaptive radiation under MR guidance, and this happens live as well. And then the last thing to be added to our palette would be protons, which we are very lucky to be there in February 2026. These are just some pictures of the machines that we have. On the left, you see the variant true beam. On the right, you see the Radixact with tomotherapy capability. On the left, again, there's a Meridian or the MRI guided radiation therapy. We are the only ones in Palm Beach County to have that. That's on the left. And on the right, we have the CyberKnife for precise delivery of radiation as well. And then these are just some studies that we typically use. There's no need for me to go into much more detail about them, but these are the studies that we use for endometrial carcinoma treatment. This study is currently accruing and or is almost completed accrual, but but results are being tabulated right now to make sure that different kinds of endometrial cancers based on genetics are then put in different bins for treatment options. Some FDA has also approved some immunotherapies for endometrial cancer, which Dr. Morrissey will talk to you in more detail about: pembrolizumab, dostarlimab, and durvalumab. Early stage endometrial cancer, again, and locally advanced endometrial cancer. In both of these cases, radiation therapy is usually used. In early stage endometrial cancer, surgery can be effective for very, very early stage, good histology endometrial cancers. Locally advanced endometrial cancers typically would always require radiation, and a lot more times would require. Sorry about that. I don't know if you're seeing it on my screen, but something just popped up. Just unlock it. Oops. Oh gosh. Okay. For locally advanced endometrial cancers, typically you would always need radiation plus minus chemotherapy, and sometimes immunotherapy as well. So cervical cancer, some of the recent data has shown that adding pembrolizumab has given better outcomes. And in some of the cervical cancers, induction chemotherapy is also playing a decent role in outcomes. Thank you. And I can take any questions later on once Dr. Morrissey does his presentation.
Thank you so much, Dr. Saeed. As it happens, we heard from Dr. Morrissey. He's in the OR and he's going to be there for another almost an hour. So although we miss him, we agree that he's where he needs to be with his patient. And kudos to Dr. Saeed. That was such a comprehensive presentation. And I love the way that you explained the myths to us and gave us the facts in such detail. I think that's something that most of those myths are things that we've all heard. And so we appreciate you clearing that up for us. And kudos too, like this shows you how we really do at the Lynn Cancer Institute work together in our multimodality concept. And Dr. Saeed truly presented that today in this presentation. So thank you, Dr. Saeed.
Thank you for having me. And I can take any questions from a radiation standpoint, medical oncology standpoint, or even GYN oncology standpoint.
Okay, there are a couple of questions. The first one said great presentation. So that was a compliment, well deserved. And the next one is, are these cancers found during routine pap smears?
So not all of them would be. It's a great idea to have routine pap smears to not miss on your screenings. The most likely, the most positive outcomes that we can obtain are from an early detection. So if your pap smears are up to date and you're having a clean green slip from your GYN oncology, from your GYN or OB/GYN, is great. But that does not mean that ovarian cancer, something like ovarian cancer or vulvar cancer, cannot be brewing in the background. So please make sure that any of your wake symptoms get attention as well. And it's okay to see your physician, and the physician can satisfy you and tell you that, you know what, it's fine, this is okay. Don't feel bad about it. It's okay to see them. And it's okay for them to tell you that this is fine or this is not fine. But don't ever worry about seeing someone for a vague symptom.
Good advice. Any other questions? Yeah, as I said, that was so comprehensive, Dr. Saeed. I think that you gave us all the answers to a lot of our questions. So, as always, here's another question. My OB has been saying that PAP just needs to be done every 2 years if with the same partner. But isn't it better if we get it done every year?
Great question here too. So if I was not in the medical field, I would have exactly thought about it like this too. But what they have shown from studies and studies that if you are with the same partner, that doing it more than 2 years is probably not going to result in any different outcomes. So it's okay to stick with every 2 years, especially if you have a history of negative pap smears.
You? Any other? Here's another one. What age can you stop checking with routine pap smears?
Again, another great question. And the problem is with this question, this is always a moving target. The guidelines are always changing as to what age would be, at what age can we say, okay, there's no more need for a pap smear. So your GYN would be the best person should be in touch with those current guidelines to tell you exactly at what age you can totally stop checking. But always check with them, always confirm with them.
Good advice. Anyone else? You can still ask questions because I'm going to be finishing up a little bit. As always, this presentation was recorded. So if you do want to watch it again or share it with someone that was not able to be on the presentation today, when Lee sends out her evaluation, you can request that she also send you the link to this lecture. It should be ready by the end of the week. And we always appreciate you completing the evaluations. It helps us and our speakers, and many people have given us ideas of topics that they would like to hear about. So please, when you see that from Lee, fill it out and send it back to her. And our next lecture in January will be on Wednesday, January 21st. And this one will be from our nutrition series, which is always important information for everyone. And the topic is Healthy Heart Reset, New Year, New You. The speaker will be Marie Mirande, our oncology dietitian. And let's see, we'll take another. Any more questions? Okay, I think that. Thank you so much, Dr. Saeed. This was
Thank you for having me.
beautiful. And thank you, everyone, for joining us. And thank you for kicking off our 2026 Zoom and Connect presentations. Have a great
Thank
rest of the day, everyone.